Sarah, Dr. Becker, and we are recording, yes. Okay, so to introduce Dr. Becker to folks that don't know her work, she is a clinical psychologist and researcher dedicated to improving the quality and utilization of behavioral health treatments for individuals with substance use disorders. She currently holds appointments as an associate professor in the Department of Behavioral and Social Sciences at the Brown University School of Public Health and in the Department of Psychiatry and Human Behavior at the Warren Alpert Medical School. Additionally, she also serves as the project director for the New England ATTC, the Addiction Technology Transfer Center, and was a previous director or co-director of the South Africa Addiction Technology Transfer Center. So, both, working hard to train many clinicians across the nation and the world. And I'm somebody as a clinician who has benefited greatly from many of those trainings throughout my years as well. So many thanks to the ATTC. Previous to Dr. Becker's work in psychology, she interestingly worked as a strategy consultant, helping companies with organizational change initiatives, and getting a lot of experience in direct-to-consumer marketing principles, which are things that have sort of popped up in her research if you follow it along. A lot of her current research is built on these experiences and extended them to what we know as dissemination implementation science work, which happened to pair really nicely with some principles from marketing and the business world. And so Dr. Becker applies these things to dissemination implementation strategies to really focus on increasing utilization of evidence-based treatment in substance use treatment. So among the many things that Dr. Becker works on, some of her larger current funded projects include a 5-year NIDA R01 to evaluate strategies for implementing motivational incentives in opioid treatment. She has an NIAAA funded PO1 testing train-the-trainer models for improving expert screening, brief intervention, referral to treatment practices in HIV service organizations within South Africa. So both, projects domestically and internationally. And she's been wading into the technology space, I believe, as well, with a recently completed R34 focused on developing a computer-aided parenting program for adolescent residential substance use treatment, which I think is being expanded out now into maybe an R01 or somewhere in that space. So yeah, I'm super excited to hear what she's been up to lately and hear more about it. I first discovered her work when I was a clinician, working as a program director in adolescent substance use treatment, and she was my first exposure to implementation science. And I just always found her work to be really easy. As a clinician, was able to implement some ideas from her work to change the way we were doing work. And as a researcher now, as I've kind of grown, I've always found her projects to be creative and pragmatic at the same time, with a focus on sort of real world application that I always find refreshing. So yeah, I'm excited to have her. And with that, here she is.
That was a really lovely and well-researched introduction. I was happy to be here already. And now I'm like really happy to be here because that was so generous. So thank you, Justin. I actually did want to publicly thank Justin. I had the pleasure of meeting him at the Addiction Health Services Research Conference last year. And we connected and had a really lovely rapport. And so he reached out to invite me. So thank you for that. And I'd like to publicly thank Jordan, who just made all the logistics incredibly seamless. I was a little bit nervous about my Wi-Fi stability today because I was getting messages yesterday that it was unstable. Seems to be okay. But if anything is happening, please just feel free to interrupt me and let me know, because sometimes with screen share, it's not so obvious. Okay, so let me share screen and we'll jump right in. So as Justin did such a great job introducing me, I've been based at the Center for Alcohol and Addiction Studies, which is at the Brown University School of Public Health since 2009. And I'm an associate professor there. And we have a very long-standing tradition there that whenever we have outside speakers, we ask them to start with a personal story or vignette to share how they got interested in their program of research, to just try and bring a slightly more collegial and interactive tone to the talk. So I decided to bring that tradition with me. And Justin actually sort of got at this in his intro to me, which is kind of unbelievable. But basically, let's see, the spark came from my days in consulting, the spark for this current program of research. I worked at the Boston Consulting Group which is a strategy consulting firm. It's often referred to as one of the big three, with the other two being McKinsey and Bain. And basically, they consult to Fortune 100 companies on all aspects of their business strategy. And I was situated in their healthcare practice group, working primarily with pharmaceutical and biotechnology companies. And a really fun fact is that I worked there with John Stevens, who you would now know as John Legend. We worked together in the Boston office. I love this headline. This is from the BCG alumni site, where they're like, BCG alumni John Legend, as if that's his claim to fame, that he's like a BCG alumni as opposed to an EGOT winner. But basically, we worked there together. We both decided that consulting wasn't really the most fulfilling career path for us. And so he left to pursue a music career and went on to be one of the most celebrated musicians and songwriters of all time. And I left to pursue a career in academia. So I would say that we are both totally crushing it in life and both doing really great. So the other fun facts that happened while I was at BCG is my first year there, a partner wrote a book called The Change Monster, and all employees got a free copy. And I ended up reading and devouring this book. And it's all about just the principles of how scary change can be, especially for organizations, and how difficult it is to get an organization to adopt a new practice. And I found that to be just really formative and interesting. And right at the same time, I was working with Bristol Myers Squibb when they discovered that Abilify seemed to have a promising signal as a drug. And what really, I think, caught my attention was just how swiftly they all coalesced around that promising signal and started convening cross-functional teams to craft a marketing strategy. And marketing was just so central to their mission in terms of thinking about both what was the message for the providers that would be prescribing Abilify, and also what was the message for those that would ultimately be using Abilify. So then fast forward, I decided to leave BCG. I went to graduate school in clinical psychology. I was studying adolescent substance use interventions and learning that some interventions were better than others. And these observations I had in business, both about organizational change principles and how difficult change is, and also how important marketing is, was completely absent from my training. And so when it was time for me to start a postdoctoral fellowship, I was like, that's what I want to do. I want to do something to improve outreach. I want to improve marketing. And I didn't even really know the phrase implementation science at the time, but that's kind of the work that I've taken forward since then. And these observations continue to really be foundational. I would like to acknowledge I'll be talking about a number of different projects today, kind of at a quick pace. And so I would like to acknowledge the funding. And also, in full disclosure, some of the best background slides that I have are actually publicly shared slides from a training institute that I attended funded by the NIH, created by Dr. Zanola Proctor and Larry Green, who are faculty at this institute. If I'm able to pique your interest today, I highly recommend institutes funded by the NIH focused on dissemination and implementation science. On any given year, the specific institutes change. The one I attended, TITRE, is no longer available, but there are additional institutes that keep popping up. So if you're interested, please contact me afterwards and I'm happy to share resources. You also have a phenomenal implementation science hub at UW that also has a lot of great resources. All right, so our goals for today. I'm gonna very quickly go through the what, why, and how of implementation science, just so that we have common terms that we're using. And then I'm gonna really spend most of my time talking about two case examples. And I specifically picked an example that shows my work implementing evidence-based practice in usual care settings, and then another example that talks about my work in marketing interventions, just to give you a flavor of the different types of approaches that I use. All right, so the what, why, and how. What do I mean when I say implementation science? Basically, I'm talking about work that attempts to bridge the gap between what we know in terms of public health knowledge and what we do in public health practice. And I would say that historically, this is talked about as one gap. We talk about the research to practice gap or the evidence to practice gap. And I would argue that there's at least two critical gaps that we need to be thinking about. I also want to just say, you guys, I think at the BRiTE Center do a lot of what I would call health services research. And so just to say, you are probably doing research that is overlapping with dissemination and implementation research already. This is just a schematic of just some of the ways that dissemination and implementation science interact and overlap with other spaces. I'm going to give you the official NIH definitions in a moment, but I generally think of dissemination research as attempts to spread lots of information and communicate with the goal of building awareness and knowledge. And then implementation research as attempts to really integrate a specific innovation or practice into a usual care settings. You can think of dissemination research as overlapping communication efforts, and dissemination research overlaps health communication, and implementation really overlaps quality improvement if you work with colleagues or you yourself are doing work in the medical center. One thing I also like to just quickly note is, by definition, you are probably all always doing research dissemination and research implementation, which I would describe as something like this, giving a talk, publishing your work, going to conferences. That's research dissemination. Research implementation is taking that work and helping folks to implement it without studying it scientifically. When you flip it and you call it dissemination research and implementation research, the key difference is that we're talking about the scientific study of the best way to do it. So I'm right now just giving a talk, but I don't know if that's an effective thing at all. A dissemination research study would actually assess that to see, is this type of approach effective? And likewise, implementation research would study the approaches to implement something in usual care. So why do this? I like to show this photo and claim that I took it of the Addiction Treatment Center treatment system. This is actually the Grand Canyon, of course, but basically the addiction treatment system is incredibly siloed and fragmented. And we often think about it as characterized by this one enormous gap, as I mentioned, the evidence to practice gap. And I would argue that there are multiple gaps we need to be considering. The first, which is the one I'm sure you're most aware of, is the research to practice gap. This is the gap between the care that could be and the care that is available in the community. This is very well documented by the Institute of Medicine, multiple landmark reports. And one of the big takeaways is they don't think the word gap is strong enough to describe the problem. They call it a chasm. So there's a quality chasm between what we know works and what's available. And they've also done follow-up reports documenting that the chasm is greatest in substance use and mental health settings, greater than in physical health settings. Surgeon General's reports in addiction have been documenting for years the unique challenges in our field. I would say in addiction, one of the biggest challenges is there's a lot of ineffective treatment in the community. A lot of providers are confronting patients, telling them they need to quit, things that we know are not effective at all. And there's a really nice report that I find myself summarizing a lot by McClellan and colleagues that just characterized the addiction treatment system and all of the gaps that make it really hard to deliver a quality product. The good news is there's been a lot of investment in this space. So you all have a CTN hub at UW. This is funded by the National Institute on Drug Abuse to take promising signs from clinical trials and test interventions out in community settings. And then myself and Brian Hartzler are both principal investigators of SAMHSA-funded training and technical assistance centers, which are also similarly charged with helping to improve access to effective treatments out in the community. The other gap that's enormous in the addiction space that I don't think we pay enough attention to is the level of unmet need. And so on this graph, you're seeing in the darker orange, the percent of folks in the US population that meet full criteria for substance use disorder. And then you're seeing in the lighter orange, the percent that receive any treatment at all, any treatment. So not just substance use treatment, actually. And the vast majority will get no service at all. So less than 10% of teens, less than 10% of young adults, and slightly more than 10% of older adults will get any type of intervention. This gap is highly pronounced among racial and ethnic minorities and those of lower socioeconomic status. And interestingly, national data has actually asked people why. So if they meet criteria for a diagnosis and they don't get care, it'll say, why didn't you get care? And the answers are usually, I'm not ready to stop using, I didn't think treatment was needed, and I didn't know how to get help. So that suggests that our regular attempts to address the evidence gap by improving the quality of care in the community is not going to be sufficient. We have to be approaching things from two sides. I was an econ major in a former life, and so I tend to think about this as supply and demand. Like the first gap is what I would call the supply gap. There's not enough effective treatment in the community. There's also a demand gap, that we don't have enough patients who need treatment seeking it at all. And so we need to be thinking about intentional ways to do both. And I would argue what you guys do at the BRiTE Center with digital health, you could really frame as attacking both of those gaps depending on your target. All right, so a little comic relief. What is the status quo in the field? So we've got a little guy fishing and we have some folks in a hot air balloon. The folks in the hot air balloon say, where am I? And the person on the ground says, you're 30 meters above the ground in a balloon. To which the folks in the balloon say, ha ha ha, you must be a researcher. And the guy on the ground says, yes, how did you know? And they reply, because what you told me is absolutely correct, but completely useless. And I would say that's really at the heart of what we're trying to do when we talk about doing effective and pragmatic implementation science, is that we're trying to do research that's not just accurate, but is useful, and it's useful to the specific context that we're working in. Okay, and so one more quick slide to kind of bring this idea home of what makes implementation science different. What you see on the screen in front of you on the left, we have quality improvement initiatives, empirically supported treatments. On the right, we have patient outcomes. The status quo, we look at the effect of a treatment on patient outcomes. Implementation science is concerned with all the space in between. So we're interested in the how. So how do you get people to deliver your intervention? And we're interested in an entirely different set of outcomes. So things like, was the intervention feasible? Was it acceptable? What were the costs? Did people deliver with fidelity? We also look at things like, was it delivered with equity? Was it delivered in an efficient manner? And so all of that space in the middle, the contextual factors, really become the core of implementation research. And those are the types of themes I'll be talking about today. All right, so I'm going to dive into some cases. The first one I'll probably spend a little bit more time on because it's a more complicated project. And this one is an implementation research example. And this is one of the studies that Justin mentioned. It's a study called Project Mimic, Brian Hartzler's COI. It stands for Maximizing the Implementation of Motivational Incentives in Clinics. Every good study needs a good acronym, right? And in Mimic, the acronym stands for kind of like watch it be done and mimic it be done. And also the fact that we're trying to get these incentives out in clinics. And basically the focus of this study is addressing the opioid overdose epidemic. At the time that we were starting this study, about 2 million people in the United States were dying had opioid use disorder, and about 130 people were dying every day. The good news is that opioid recovery is possible, and the frontline treatment is medication. Medications like buprenorphine and methadone, and they are extremely effective, but they are not a panacea. For most patients, they are necessary but not sufficient. Patients treated with medication, about 37 to 50% do not comply, and about 60% relapse within the first 6 months. For this reason, NIDA's strategic plan in the last 5 years really emphasized that research should focus on medication combined with behavioral interventions. And by far the most effective behavioral intervention as an adjunct to medication is something called contingency management, which is a treatment that gives patients incentives for meeting treatment goals. I talk a lot about what I would call the contingency management paradox, where contingency management is the most effective treatment, but it is the least available in community settings. And that's actually shown by data. If you survey national providers, they're more likely to tell you that they are arguing with their patients than they are to say that they're using contingency management, even though contingency management is by far one of the most effective behavioral interventions. So that's why we developed Mimic. We were like, let's see if we can help opioid treatment programs that dispense medication to adapt this highly effective intervention. And so here on the screen in front of you is a visual of our trial design. If you look at the colors, so on the left, we have the research pipeline going from efficacy research to effectiveness to implementation. And so if you have effectiveness in yellow and implementation in blue, hybrid designs are the green space in between. And this is what we would call a hybrid trial because we are looking at both implementation outcomes and patient outcomes in the same trial. We do this, I could talk about this for another hour. We do this because the typical research pipeline, it takes 17 years to get 14% of research into usual practice. And so hybrid designs are one really effective way to try to accelerate that research to practice pipeline. So I'm going to talk you through each of the elements of the study now. So our evidence-based practice, as I mentioned, is contingency management. Contingency management can be designed to target all sorts of things. It can target abstinence, it can target attendance, it can target treatment goals. It can also be done with vouchers, or it can be done in a low-cost way. We decided to use a low-cost model because it was one of the models with the most evidence and support. We used a model that was used by the NIDA Clinical Trials Network, developed by Nancy Petrie and colleagues. I don't know if you all knew Nancy Petrie. She tragically died 2 years ago, at a very young age, but was really a pioneer in this space. And really, the low-cost model takes into account the excitement of chance. So patients can earn draws from a fishbowl. Half of the draws are just encouraging phrases, and the other half are a mix of small, large, and jumbo prizes. The average cost of a draw is $2. The patients are really excited about the chance of earning that $100 jumbo prize. We actually did qualitative formative research with 11 opioid treatment programs throughout Rhode Island before we decided to do the large-scale implementation rollout. This was as part of a P20 project. And without going into too much detail, the organization shared that they thought tracking attendance would be the most pragmatic for them. They felt like there was a lot of barriers to doing abstinence because a lot of them had state regulations. They had to ship urine screens out. It would take too long to get the results. So basically, we did a very pragmatic attendance goal, and each organization made a very flexible goal where they could decide if they wanted to target dosing, if they wanted to target individual group, whatever was most really important for them. I'm going to talk about our implementation strategies in greater depth because I think if you're all thinking about doing work in this space, that's really, I think, always the big question of like, what does the strategy look like? But our outcomes, we were most interested as our primary aim in could we get people to do CM well? Could we get them to do contingency management? So our measures were a measure of exposure, how much CM patients were getting, the skill with which providers were delivering it, and could they do it after we removed our help? On the patient outcome side, we also looked at, did our implementation strategy help patients to actually cut down their opioid use and to attend their sessions? And we looked at some organizational mediators, because as I mentioned, that's an interest stemming back for a long time. And we looked at leadership, engagement, and implementation climate. Let me tell you a little bit about the strategies we use, because I always feel like that's the black box of implementation. We used our ATTC standard strategy, and I did again want to shout out that you guys have an ATTC hub at UW. So if you're ever interested in a training or implementation project, Brian, who's on the phone, would be a great contact for you. We actually used the training approach that our SAMHSA-funded ATTC uses as our credible real-world control, because it's what we're already doing when we train folks out in the community. We had the benefit of longstanding regional connections, and we had some pilot data that our training approach was effective. We use an approach called the Science to Service Laboratory, and basically it consists of didactic training, performance feedback, and ongoing leadership coaching. We had some nice pilot data that we've published looking at our Science to Service Laboratory approach relative to just didactic training, which was the state of the art at the time. And basically we tested it in 18 clinics, 7 in our region received our fancy strategy, and 11 others received just didactic training. And we followed providers for a year. And what I'm showing you on the screen now is the rates of contingency management adoption over a year. Each of the numbers on the bottom is a 4-week period. And so what you see here is that our fancy training strategy looked pretty good, right? You know, we had really much higher rates of adoption, but there were 2 problem areas that really jumped out at me as someone that wanted to improve how our training center delivered interventions. And I would say those were really the ends. We had the issue that it was really slow to take off, and 5 months is a long time when you're trying to get an organization to buy in. So it took almost 5 months to really see a positive effect of our implementation strategy. And also near the end, as soon as we removed our support, which was around 9 months, we started to see what we'd call a voltage drop. So we really wanted to improve the acceleration and the sustainment of our strategy. So that's when we looked to the literature and we decided to add 2 promising, I should say, implementation strategies. The implementation sustainment facilitation, where a coach is providing ongoing support targeted at helping an organization to sustain. And we also let providers earn some incentives right up front through something called pay for performance, because that's really been shown to speed things up. So that's what we decided to test as our enhanced strategy. And here's our kind of logic model. We were hoping that we believed contingency management could help to improve outcomes, and we believed our ATTC strategy could help improve staff knowledge and skill and would therefore help improve the entire chain. And we thought our enhanced strategy could really improve organizational factors. We thought the facilitation would help with things like the intervention being expected, supported, rewarded, and being delivered in a more consistent way. So the focus of our enhanced strategy is around leadership engagement and implementation climate, which is really the center in the red box. Okay, so it is a work in progress. We are now well into our 2nd cohort, and I'm just going to tell you a little bit about what we did in our 1st cohort. One of the little strategies I would give if you're ever interested in a cluster randomized trial, which is the approach we decided to take. Our statistician told us we should have 30 sites, and I just did not feel like we could manage 30 sites at a time. So we basically did 3 cohorts of 10 sites. It helped us with managing our cost and managing our time and our research activities, and then we control for cohort as a variable. So we are now at the start of cohort 2, and I'm going to tell you a little bit about cohort 1. So in the implementation field, there's all different kinds of frameworks. One is called the EPIS model, which stands for exploration, preparation, implementation, sustainment. It's basically phases of activities you should do. And so we followed that model. The exploration phase was that qualitative work I showed you earlier. And then this grant was the preparation, implementation, sustainment. And basically we did a lot of training. So Justin mentioned before, lots of ATTC trainings. This was both conditions got this. This was in both ATTC and enhanced. Very interactive trainings. That's me doing a fishbowl with someone. And here folks are doing lots of role plays. I should say we did this in cohort 2 during COVID. And so if I were to show you cohort 2 pictures, it'd be all like Zoom breakout rooms, lots of people. We had a virtual fishbowl generator. Everything was done virtually. That is something I absolutely love to talk about. And Brian and I are really interested in doing some cost effectiveness work on this, just to see how our training was, whether it was equally effective and cost effective during COVID. But here are pictures of our face-to-face training in the before times. And then we also have a big performance feedback element. And basically after people attend our training, they have to submit a role play to us. Just an audio recording of them doing contingency management. There's a well-validated scale that Nancy Petrie's team has used that rates contingency management. And we just require an adequate score on that to basically be ready to progress to the next phase. Once they're in active implementation, the ones that I mentioned, some providers could earn bonuses, they have to get a higher goal. And that goal is actually taken also, again, directly from the literature and from Nancy Petrie's work. There was a very clear benchmark in her prior work of what would be a stretch goal. We developed a novel tool to capture CM outcomes. I would say that was one of the biggest puzzle pieces for us. We were like, how do we get outcomes from 30 opioid treatment programs in the community, half or 3/4 of which have EMRs, but none of which have the same EMR. So we made just a very user-friendly website where folks fill out once a week, a weekly report. These are basically checkboxes, like, did you deliver CM? If you say no, everything grays out. If you say yes, there's just some follow-up questions. They do a little self-report on their fidelity, and then it makes a very user-friendly week patient flow so that people can see exactly how many draws their patient deserves that week and where they are in the program. We also helped sites deliver their prize cabinets. We did this in cohort 2, but we were all wearing masks. And we were there was no close pictures taken, but again, some before time pictures of us. And I should say each organization totally customized their own prize cabinet. So if you look closely at the pictures, no two cabinets are the same. We spent the exact same amount of money on each organization, but each organization really took ownership of doing their own selection of prizes. And then we ended up delivering 44 of our enhanced calls, and we ended up awarding only $6,000 in incentives. And I would say, talking to incentive experts, it's like really not a lot of money. So this was like not very expensive, and I'm not convinced that the incentives really added anything to our work. So if I were to conjecture about future designs, I would probably get rid of the incentives. Okay, so implications, and I'm not sure how relevant this is to your work with the organizations you work with, but with the opioid treatment programs we work with, the turnover was head-spinningly fast. This comic says, yes, we have high turnover. In fact, Mr. Hopkins here will finish your interview while I clean out my desk. That was definitely our experience. We actually had a half-page staff turnover plan in our grant, where we said exactly what we were going to do in turnover. We anticipated that 1/3 of our providers would turn over within about a year. We ended up having 40% turnover in like the first 4 months. So it's just been like head-spinningly fast, just how quickly people leave the space. So we had, fortunately, a rock solid plan. Everything was video recorded, and everything was saved so that when new staff started, they could basically just jump right in, watch our trainings, and submit a role play. And it just was kind of a spinning door of having providers come in. And, you know, I think our initial, oh, I just realized I forgot my outcome data slide. Well, I can email you my outcome data slide, but basically early data looks good. We have higher rates of people submitting tapes in our enhanced condition. We have higher rates of people getting good quality in their submission. Basically, our enhanced condition, we're seeing really good outcomes on contingency management skill. We're not seeing any difference in patients' exposure to contingency management. So it's kind of an interesting that the provider outcomes seem to be showing something, not so much on the patient side. Okay. Yeah, I think I lost a couple slides here, so sorry about that. So, but basically, this is now study number 2, and this study is designed to really be completely different. This one is on dissemination research. So this is about how do we build awareness about effective treatment. And this is a study with adolescent substance users. So this slide will look familiar to you. It's the one I showed you before. And our focus is going to be adolescents and the fact that only 9% of adolescents get any treatment at all. And I mentioned before that I tend to think about things from the perspective of supply and demand. This is actually a framework that I use a lot in my work. It's another way we can think about it in business as a push strategy versus a pull strategy. So if we're thinking about different strategies to reach our end user, a push strategy is what I was just talking about with Mimic, where I, as someone that works with treatment developers like Nancy Petrie, I go out and I'm trying to train providers and I'm marketing to them. And then they are offering what I'm marketing to them to the end user. A pull strategy, you kind of skip that stage in the middle. You're going directly to the end user with the hope that they will then go to the providers in the field and request what you're offering. So if you're making mHealth apps, as an example, you might market them directly to the end user, but maybe they need to use it in a treatment setting, and you would actually want them to be going to the treatment setting and requesting it. So there's different ways you can market and versus push or pull. I talked before about the two different gaps, and a pull strategy addresses gap 2, which is unmet need. So this study protocol is so different than the one I was just telling you about. And this was actually a 3-phase study. It was actually my early career award from NIDA. The protocol is fully published, and I'll be sending you these slides. So you'll have the link to the paper there. But basically, it was a 3-phase study, and it followed best practices in the marketing literature. My mentor on this project is actually a services marketing national expert. And basically, we first did market research. We went out into the community to ask adolescents with substance use issues and their parents how they would like to receive information about effective treatment. We then did a larger survey building on the themes we found in that market research. And then we did a randomized trial testing 2 different marketing strategies. In our phase 1 study, kind of an amazing takeaway for me. I will be honest, I went into it very naively thinking that the terms that national organizations use to market treatment would be appealing to people. So like the Association for Behavioral Cognitive Therapies, as an example, has a whole page for parents where they say, what is evidence-based practice? And they talk about it. And so I was asking parents, like, how could I market evidence-based practice to you better? They hated the term. People did not like the term evidence-based practice. And when I went to the literature, this was not at all a fluke. I'll talk about that more in a moment. But in my sample of 53 parents and teens, only one person was able to define evidence-based practice correctly. Most people thought it meant legal evidence, which I thought was really interesting. So parents were like, do you mean like CSI? Kids were like, do you mean my probation officer is going to have evidence that I'm using? And I think for the population I work with of adolescent substance users, many have legal involvement. And so that was like a big aha moment for me that we should not be using this phrase. So I'm kind of on a soapbox mission to get national associations to not use the phrase evidence-based practice in their outreach to parents and families. We can use it when we talk to each other, that's fine. But when we're talking to lay audiences, we should use simple language. And the language parents liked, kind of as a fast forward, they like things like effective, successful, proven, simple words. Okay. The finding I had was actually not a fluke. This has been replicated in multiple other settings, big surveys of health consumers, surveys of the mental health system. People just do not like the phrase evidence-based practice, so something to be aware of if you're ever doing marketing directly to the end user. We decided to survey a sample of parents, and I will say that was driven by the qualitative research. To put my marketing hat on for a second, you have your customer who you sell to, that's going to be the person that purchases from you, and then you also have your consumer. And with teenagers, that's not the same thing. So when I was doing my qualitative research, teenagers are not picking a treatment provider by themselves, nor are they paying for it by themselves. It's usually their parents that are actually the ones that are doing the research and selecting the provider, but the teenager is the consumer. So the teenager is very much invested in the service. So it just has different implications for marketing. We usually market upfront to the customer, and then we would be marketing to the consumer and making sure the consumer is satisfied with the product. But basically, so we did a survey of parents for that reason, because we were trying to get kids in the door and try to get kids to seek out treatment. And what we found was that this issue where people didn't like the phrase evidence-based practice was really pronounced among racial and ethnic minority groups, with those with lower income and those with lower education. So arguably the folks we would most want to be reaching, because they're most affected by the unmet need gap, were the ones that had the most negative impressions of the concept of evidence-based practice. We also found that education was the strongest and most consistent predictor of caregiver perspectives. We then did a bunch of other survey work. We used a popular framework in the marketing literature called the marketing mix. It consists of 4 Ps. It stands for price, product, promotion, and place. You all might be familiar with this work and use it in your own shop, but basically it's just ways to market and things to be thinking about when you're designing a marketing product. And so we analyzed consumer preferences around each of those dimensions. We again found variability by income, education, and history of treatment. We cut the data a different way and looked at it by presenting problems. We found differences there. So it had all sorts of really interesting implications for how we segment the market and think about marketing to folks from different backgrounds. So here's basically where we got to. Our last phase was a randomized trial where we took all of our survey research and qualitative research, took all the preferences parents told us about words they liked, and we made a very simple infographic. Because parents were saying, I want something simple. I want something I can get via a brochure or a poster. I want things, that I can see in multiple settings. They like social media. So we tried to make something very simple. And we compared it to what was the standard at the time that this study happened, which was just a website from the American Psychological Association. And we basically randomized people to see those 2 conditions. And then we measured, did it affect their responses on a behavioral intention scale? And did it affect their actual behavior? We had like a secret question at the end that was like, do you want, to be emailed information about therapy? And then it was the yes, no on that, whether they did. So on the left is our infographic. This was at I believe, 6th grade level. It's about 128 words. On the right is like 529 words. It's like more at a 12th grade level. And by the way, to this day, when I go to websites, national associations, I do readability tests on a periodic basis. The typical readability is like 12th to 14th grade level. I mentioned working in pharma. Most pharma ads are at a 6th grade level, and the CDC recommendations an 8th grade level. So I think part of why we see these major imbalances in our field of folks gravitating to medication more than behavioral therapy is because the information is so not accessible about behavioral options. It's a big problem. So here was our little consort diagram. We had 389 folks screened for this randomized trial. We ended up randomizing 152. The primary reasons for exclusion is we wanted teens that had done therapy. I should have prefaced this. One of the big realities with qualitative research of any sort and marketing research of any sort is that what people say they want and what people actually do are very different. So we actually tried to adjust for that in this research by using folks that had only sought treatment, and we asked them both, how would you ideally seek treatment and how did you seek treatment the last time, so that we could actually look systematically at differences between what people say and what they do. That's like a talk for another day, but really interesting findings there. Okay, the main issue was that randomization seemed to work. There were no significant differences between our groups. It was not nearly a diverse enough sample. That's like something that it's just an embarrassing disclaimer of the study. We really struggled to get a diverse sample. Okay, so basically our first question was, did our condition have an effect on behavioral intention seeking, which is on the left from a questionnaire, and then actual information seeking, their requests for information at the end of the study. I would love to show you big red boxes around condition because that's what we were hoping to find. We did not find that. We found no main effects. We found, except for a main effect of adolescent legal problems, which was super interesting to me because of all of the qualitative work where people didn't like the concept of evidence. We found that parents whose teens had legal problems just wanted more information in general. So kind of an interesting thing that this seemed to be a uniquely interested group. Okay, and then we did a moderator analysis to see, did the kids presenting problems affect whether the parents responded best to one type of treatment or the other. You guys briefly saw the infographic. It was an adolescent substance use infographic. So we wanted to look at, did a teen's level of substance use problems affect their response to the infographic, their level of legal problems. We actually couldn't do internalizing and externalizing problems because they were just so high in the sample. Like kids just in both conditions had such high problems that there was no variability. So, and what we found was there was an actual interaction, and that is not in the right spot. Okay, so those red boxes are not in the right spot. I'm sorry, I don't know what happened here, but basically the big takeaway should be that there was an interaction. If you look, the box is too low. It should be up one around condition and adolescent substance use problems. So there was an interaction between condition and substance use problems, that if a parent's teen had substance use problems and they got the infographic, they were much more likely to request information than if they got the standard marketing. So it's kind of a fun little proof of concept study that we actually could tailor marketing that seemed to work as long as we tailored it intentionally to those in our target audience. So what does that study mean? What are the implications of that one? We found that marketing was affecting information seeking behavior, but only for those targeted. And we found that specificity really matters. And this is a general marketing principle and is super well established in the pharmaceutical literature as well. We find that marketing of Prozac kind of rises requests for all types of antidepressants, but it does not increase requests for ADHD medication as an example. So specificity matters. You would expect that if you're marketing something related to substance use, it would only affect people that are interested in substance use. And then parents with legal problems seem to be really interested in getting more information regardless of what group they were randomized to. All right, as Justin mentioned, I do have a couple other projects in the hopper. So if there's stuff folks would like to talk about, I'd be delighted to talk about. We briefly had another ATTC based in South Africa. The Trump administration very unceremoniously cut us as about a few months ago. It was kind of a shame. I'm kind of hoping the new administration will start us back up. But basically, we had a training center that we were training the country in evidence-based practices, and we were able to get an NIAAA grant where we are now testing a train the trainer cascade model where we're rolling screening and brief intervention out throughout the country. Basically, on the top part is the 90-90-90 targets for HIV reduction in South Africa. It's one of the leading countries, unfortunately, in terms of negative HIV outcomes. We did qualitative work to find people's areas of greatest training needs in HIV service organizations, and they really wanted screening. They wanted screening support. So we developed a very simple, pragmatic train the trainer cascade model. And we are basically testing that now throughout the country. And we're looking at outcomes at 3 levels. We're looking at, can we improve trainer outcomes through this train the trainer model? Can we improve provider outcomes? And can we improve patient outcomes? And then my slight foray into your world of digital technology, I had an R34 that, as Justin's research was really phenomenal. Yes, it recently ended, and we did submit an R01 that scored at the 3rd percentile, so hoping it gets funded at this next cycle, we're hoping. And so, but basically, this is a technology-assisted intervention to help parents, again, as someone that works with teens, I would say it's always a really interesting question of, do you target the teen or do you target the parent? And with adolescent substance use, parent support, parent monitoring, communication is so essential, but it's so hard to engage them in treatment. So we decided to use technology because of the challenges getting parents in the door. And so we took an off-the-shelf computer program called Parenting Wisely. We tailored a networking app, and then we also customized with face-to-face sessions. And that was at the request of parents, where parents were saying, if you just give me technology, I'm not savvy enough to use it. They said, we really need someone to hold our hand and walk us through how to use it. So we have coaching sessions that's really about how to use the technology and how to use the app, how to request support, how to connect with other parents. And it's really a parent networking app. And so we had a very promising R34 and hope to be able to carry this forward in the new year. And so I've got lots of folks to thank. I realize I talked about very different examples today of projects, one on the implementation side and one on the dissemination side. And I'm more than happy to take questions.
Excellent. Thank you. Thank you, Sarah, so much. That was a lot to squeeze in there and really exciting stuff. And I think there's different connection points with a lot of different people's work here in this room. And so, or this virtual room as it would be. So yeah, opening the floor up, we've got 10, 15 minutes of time for questions, comments. Yeah, what do people have?
It looks like Joe Glass is on the line, who's a very strong implementation scientist as well, right in your backyard.
Hi, Sarah.
Hi.
Thanks for the shout out. Loved your talk.
Yeah, thank you, Sarah. I have a couple of questions about your CM implementation work. It was really, really interesting stuff. And if you could comment a little bit on what some of the most significant barriers seem like qualitatively in your experience working with a lot of clinics trying to implement CM. And then if there was if there were clinicians who wanted to implement CM in their clinics, like what would they do if they weren't a part of a study? Like where can they go, or what would you advise them?
Okay, I'll do so in terms of the biggest barriers, I mean, we did have COVID hit partway through, so I'll try to answer this in the like pre-COVID times. Obviously, COVID has made an entirely new set of barriers. I would say the biggest barrier that I have found is, and the biggest predictor of success, is the extent to which there's a leader or champion that's just really engaged. We've had some sites where there are individual providers that are really keen, they try it with patients, they really like it, but then they feel like they're not getting any support at their organization. So they're like, I'm the lone wolf, like trying to do this intervention, but no one's helping me, to keep the cabinets stocked or, to schedule this with patients. And the sites that really had a very clear champion that was excited and that it was going, it just feels qualitatively different when you talk to them, because people are like, oh yes, we're having weekly team meetings. It's on the agenda every week. And so it starts, I think, with the leadership, but then it's the ability of the leaders to integrate it into the regular workflow so that it doesn't feel like CM is something extra they have to do. It's just something they just add into the sessions they're already doing. But to get there requires like someone to be excited about it and to get it going. I would say during COVID, one of the things that's been most fascinating for me is that we had one cohort that was trained to do contingency management, which is an intervention that kind of requires a lot of logistics. There's like, at least the model we're using, there was a fishbowl, there was a prize cabinet, there was a lot on site. And we found there were sites that were rocking and rolling, they were implementing extremely well. And then when COVID started, they just couldn't shift to delivering it through telehealth. And so we had tools and we had like little random number generators and ways to show the prizes via Zoom and ways to do it all remotely, but people just couldn't make that shift. But yet we're training a new cohort fully remotely during Zoom and it's fine. And so I think there's something about like teaching people more flexibly. So that's a big lesson for me, that now when we train in CM, we're like, here's how you would do it face-to-face and here's how you would do it remotely, just to give people the ability to be a bit more facile. Oh, and then how would people get it? So that is actually something, your own local ATTC has great expertise in CM and does a lot of CM trainings. And then we in New England ATTC do trainings in CM all the time. And so when people are interested in doing it, like outside of our study, we would offer them, didactic training. In my region, we work with Carla Rash a lot. She's based at UConn Health, and she does training and then ongoing consultation and coaching.
Sarah, would you mind if I just stepped in? Just
yeah,
quickly,
of course.
try to help address this too. So great questions, Kevin, and wonderful presentation, of course, Sarah. I just love learning more things I didn't even know about my collaborators. But I think Sarah's suggestion of engaging organizational leadership is right on the mark and critical. And I guess part of this that I would add to that equation is the importance of, especially with something like contingency management that can be highly customized to setting, is rather than taking something off the shelf and presenting it to them or out of the ivory tower, as more often happens, and saying this is the protocol that has been empirically validated in so-and-so's trial, is to be able to say this is an approach that's been studied for 50 years, has been empirically validated in a variety of different protocols. We want to help you build something that works with your needs and resources in your setting, and then engage that leader in a process where they help define and own the programming they develop. That's how you're going to come up with programming that's not just going to work initially, but that's actually going to be sustainable, where that organizational leader is going to have the confidence and the infrastructure around him or her in her organization to adapt that programming in the future in response to changing circumstances. So those are the kinds of, that's where implementation research needs to cross a different gap perhaps into implementation service work. And that's, I think, what the ATTCs do. To just, one more 30 seconds on this is that we, the Northwest ATTC has created a pretty comprehensive online training based on some of my work. And I think some of my work is very consistent with ideas that Sara has mentioned here. And that's something that's available on our website. I put that in the chat box earlier, but people are perfectly welcome to come to our website and take a look at that. It provides comprehensive implementation support, different modules for organizational leaders, for clinical supervisors, for direct care staff in kind of a coordinated way. And that's, again, not so much a primer for what contingency management is. This is for organizations that are ready to go, that want to implement contingency management and do it in a customized, kind of tailored way for their setting.
Thank you both. That's super helpful.
I had a comment, and I'm searching for the exact question that I have, Sarah, but given your expertise, I wanted to ask it here because it touches on just so many things you said. In terms of the contingency management, right now, I think that there's a big problem with the digitizing them and then implementing them, the contingency management products, because some of the current off-the-shelf products actually give out incentives that exceed thresholds that are allowed, legally. I mean, it depends on the agency's interpretation of the policy. But what I'm finding is that, we have delivery system partners on board, but the implementation barrier is the legal interpretation of, how do we interpret these laws? Is this product offering contingency management in such a way that that we could be held, we could be dinged for fraud, waste, and abuse? So I guess I'm just kind of wondering, I think it gets to the point that you're making, that maybe some of our implementation science work needs to be service work to change policy. But I'm wondering if you have any thoughts on influencing the legal teams, or where would you go in this problem?
Boy, so Joe and I are part of a team that just was trying to submit a NIDA P50, and one of our advisors is Rick Rawson. He and Wesley Clark have been really active in this space of advocating for change of this policy. This is, I think, what handicaps contingency management all the time, is that the legal limits are just too low of what people are allowed to do. I was at a SAMHSA meeting. I mean, everything's in flux right now with new leadership. I was at a SAMHSA meeting with the last leaders where they were going to let people use their state opioid response network funds, or sometimes called STR, state targeted response, and allow them to use up to 200 a person, which is actually a big improvement from in the past. But I'm not sure if anything's been codified. There is a rumor that there's someone in the Biden administration that's like open to removing caps for contingency management, but I'm not sure what to say because I know Joe's really involved in this space too. I think we just have to keep advocating and being a voice that it's an effective intervention. And I don't think we study enough prizes that are very high value for patients, but that are not cash. So I guess that's something else I would just put a plug. Like when you go to this is not true at every program, but there are some programs, especially pre-COVID, that when you ask patients to give you ideas for jumbo prizes worth $100, they will say free parking, or they will say front of the line passes, because the culture at the methadone clinic is such that they're trying to get to work and they have to wait in line for 20 minutes and they have to park like 5 blocks away. And so I don't think we do enough of kind of working with patients to understand, are there products that are worth, $1 for you, or worth $20 for you, or worth $100 for you, that actually don't cost that much. And I do think that's kind of a frontier that we could be exploring more. And then
Thank you so much for this talk.
Oh, sorry, my pleasure. Go on.
I have a question. So I thought it was really interesting to hear you talk about that there are a lot of differences between what people say they want and what they actually do. Mm-hmm. Were there any surprising findings that you were able to gather from some of these reports during your qualitative research?
Yes. I don't think it's that surprising when I share the results with you, but you get a lot of parents will tell you, ideally, I just really want a great quality provider. I want someone that my teen really connects with. And then you're like, okay, the last time you searched for service, how did you search? And it's like, I went to the place closest to my house, and I went to the place that could get me in the most quickly. So I think there is kind of this tension where parents in an ideal world would really like to be making decisions about the products and services that they access based on their needs. But a lot of times it's just like the urgency of, who can see them.
Sara, thanks so much for a terrific talk. I've got one very, very targeted question that I'm hoping we can get your insights on. It's contingency adjacent, but certainly implementation relevant. So we have a study where we're implementing an intervention using two modalities at community mental health centers, and one of the things that we've just introduced is the option to incentivize. We're working with and through the clinicians to get the intervention out there. And one of the things that we are now authorized to do is to use various small gifts, whether it's gift cards or meals or things like that, to mobilize the clinicians to do more of what is in the original implementation plan. And I'm wondering, in a very quick snapshot, if you have ideas of what is the right way to do this? What are some things to avoid? I have some hesitancy about using incentives as part of an implementation strategy. It's not really part of it, but we're using it to kind of boost things and build morale. Maybe we can build it into it. Any thoughts and insights that you might have about how to engage the clinicians with incentives would be greatly appreciated.
Yeah, I think it's great that you're considering that. So my MPI, Brian Garner, that's actually one of his areas of expertise, is pay for performance incentives and just provider incentives in general. And I've seen him kind of get into philosophical debates with folks at Brandeis that have done these major statewide provider initiative studies that they have found that they're not helpful. But I think the big difference is that their studies, the awards are done at the organization level. So they'll do things like, if everyone hits a certain target, the organization gets, a big bonus or a pizza. I don't think that helps. I think it really has to be provider specific. And I would say the same principles of contingency management. You want that it's frequent, that it's timely, and that it's measurable. And so if it can be very clear, and I think something else that comes up with contingency management is the perspective of equity. You don't want patients or providers to feel like, wait, why did that patient hit it, when they only recruited 2 people and I recruited 3 people and I didn't get the prize. And so you want that whatever you're incentivizing to be super clear so that everyone knows what it is and there's no ambiguity about why some person gets the incentive and why someone else doesn't. So I think however clearly you can codify it so that it's attainable for everybody and that you can do it on predictable time intervals is great. We in our study do it based on monthly audio recordings and based on the number of sessions they provide to patients. So those are kind of our clear metrics. Just, once a month, you get an opportunity to send us a tape. If the tape meets a skills benchmark, you get $50.
That's very helpful. Thank you.
One practical idea too that you might consider is continuate. I've seen some programs that manipulate continuing education accounts for staff to be able to seek out professional education opportunities. That's something that could be, it's still a little bit fiscal, but it's not entirely fiscal, like paying somebody to do good practice. So, it's those kinds of things. I think it's just about being creative about what's going to be a hook, but also what is something that can be equitably kind of distributed and practically done.
Much appreciated. Well, I see we're also out of time, so I want to be respectful of that. Sara, that was terrific. Thank you so much for such an interesting and well put together talk. That was great.
Thank you. So I sent my slides through, but I'm going to add the one slide that was missing. so Jordan, expect that from me and I'll get that to you. I actually have an ATTC staff member who's been with me 8 years who was poached by pharma, and we're having her going away party now, but I'll get it to you a bit later today.
Enjoy your party.
All right. Okay. Bye-bye, everybody.
Thanks, Sara. Good to see everyone.